Oh. Hello. Damn. Oh. Greetings, everybody. We start in 20 minutes. Is anybody here? You don't have to talk. Good morning, Jojendra Sheng. Good morning, Joseph. Good morning, Lewis.
Are you, John? Can you hear me?
Hello, Llewellyn.
Are you, John?
How you doing?
I'm good. How are you?
Good. Hey, do you have a relative on the panel?
A relative? No, on the
Is that a brother?
Which one?
There's a Pediatric.
Oh, no, that's my esteemed better half.
Oh, okay, okay. She's also a pediatric neurosurgeon?
Pediatric sort of neuro rehabilitation, pediatric surgery. Yeah.
Oh, good, good.
Yeah. How you been, John?
Good, very good. Things are moving well,
Okay.
getting more established
Fantastic.
and getting alignment with the hospital. A hospital wants to have a channel and to broadcast regularly.
Oh, that's amazing.
So yeah, it's good for me.
Yeah, yeah, yeah.
Because most groups like yours, they can't really afford to pay.
Yeah. Oh, so
You
the
know.
hospital subscribes as a, okay, okay, I get you.
Yeah. And
Yeah.
is this the second time you've had Jack?
No, first time I've had Jack. You may have attended on a previous, but the first time.
Yeah, it may have been another conference, I think. He doesn't remember, but I met him in Mexico a couple of years ago.
Oh, okay, okay.
And a pediatric, he doesn't remember. I was just another person. I was broadcasting from Mexico City. And
okay.
yeah, it was in a beautiful auditorium. Wow, it was like a museum.
Yeah.
It was gorgeous. It had all this artwork from the famous muralists of the Mexican era, Mexican muralists they call them.
Okay.
And they had all this artwork around. It's a very beautiful place.
Okay. Okay. So I asked Jack to join a few minutes earlier, like 15. I see he hasn't.
Yeah. Okay.
Okay.
Okay. Here's Mohammed. Here's Mohammed now.
Okay. I wonder if I should just call Jack quickly on WhatsApp, just to make sure that everything's all right there. How you, Jack?
Yep.
You're right. Are you
Just getting ready to sign on.
okay? Okay, fantastic. I thought I'd just check on you quickly. All right, I'll wait for you to sign on there.
Okay.
Okay,
Hold on.
perfect. Thanks so much. Bye. Okay, so Jack says he's just busy getting ready to sign on. Is Mohammed there? I see you've.
Yeah, Mohammed. Well, let me get him in here. Yeah, he got in.
Okay, great.
Hi.
Hey, Mohammed, how are you doing?
Hi, John. How are you?
Very
Good to
good.
see you.
Nice to see
So long we
you.
didn't meet. Hi. Everything is fine.
Good.
Yeah. Hi, Llewellyn.
How are you, Mo?
How are you?
I'm all right. How are you, man?
Yeah, great. Just finished surgeries.
Oh, okay.
Just on time, huh?
Yes, on time.
Yeah, so I just chatted to Jack now. He says he's joining, so we'll keep an eye out for him, John.
Okay.
Okay.
Yeah.
How many?
Do you know how this works, Mohammed? You know how the Zoom works? Because I can make you co-host.
Yes.
Which I'll do anyways. That means you can admit people. Okay, let me make you co-host. Both you guys, I'll make co-host. And that means you can go over to the panel on the right. You see the panel on the right?
Mhm.
You can let people in. It'll say admit to panel.
Sure,
Go
sure.
over the more.
Yeah.
Go over the more and it'll say promote to panelist.
I've just promoted Jack now.
So
to
you can yeah, when Jack comes in, there's Jack now.
just promoted him. Yeah.
Okay, I promoted him to panelist. He got the VIP treatment, got rid of it.
How you,
Okay.
Jack?
Good day,
hear me now?
Dr. Walker.
Good morning
Morning.
or good evening.
Any snow out
Hi,
there in
good
Utah?
evening.
What is it now? It's oh, May. That's right. There's no snow in Utah now, right?
It snowed pretty close last night. It snowed in the mountains, but not down in the valley.
Oh, really? So people still skiing.
Well, the slopes closed the end of April.
Oh, okay.
But we're ready for some warm weather.
Good.
So Jack, John says he remembers you from Mexico. There was a course you did there where he was involved a couple of years ago.
Oh,
Oh,
gosh.
you don't remember me, Jack. I was one of the many people there. That was like, it was 4 or 5 years ago. Mexico City.
Yes. Oh, yes.
It was at the Hospital Infantil.
Right.
Infantil. That was a long time ago.
I
I was just
that
one of the
now.
crowd.
Me too.
And Jack, you remember Mohammed, hey?
I do. Good morning.
No.
Good evening.
Yeah. Hi, Jack. Good evening. How are you?
I'm good.
Good to see you.
Very good. Nice to see you. Thank you.
Okay.
Okay, we got 5 minutes.
Okay, great.
So can I try to share my screen and
Yeah,
see how
sure.
that
You
works?
you have any videos or anything you want to test?
I have a, there we go. I think that's,
There we go. Yeah, perfect. You want to test any video? That's perfect.
okay.
Yeah, you have any videos you want to test?
No, just,
No, okay.
yeah, we'll see how this goes. I've kind of put together some of my, my thoughts, so we'll see.
I think it'll be just fine, Jack, just fine. So what we'll do quickly then is usually we have the CAANS people, so Moody and and Bello, just introduce them quickly, and then Mohammed, and then I'll introduce you, Jack, just to the crowd. Generally, the numbers pick up as we go along. Like I said, they're normally sort of, between 50 and sort of 80 attendees. So should be a nice crowd. Yeah, but I'm looking forward to it.
Well, I am too. Should be fun.
Yeah, it should be good fun. Mohammed, what's it like in Egypt at the moment?
Sorry. Yeah.
I mean, what's it like weather-wise in Egypt at the moment?
Now it's like 30, 32
Oh,
in the morning. Yeah. And 20, 22 at the evening and night.
okay, yeah.
Mohammed,
Yeah, it's getting too warm.
Your internet is better, in Mohammed. Did you do something to it? It looks your picture looks clearer.
Yeah, you think so?
Did you picture you make your internet more powerful or something?
No.
No,
It's
the same,
just the
same.
mobile. I'm using the mobile this time.
No,
My
I don't know. To
cellular
me, it
phone.
seems
Maybe the 4G.
Does it seem better to you, Llewellyn, than it usually is? Because sometimes it's a little rough.
No, it does.
No,
it does.
yeah, it is. It's the voice is nice and clear. Slow the pictures.
Just see who we have away. Attendees. We don't want to leave anyone necessarily. Can I promote some people to panelists?
Yeah, sure. Anyone that you see should be promoted.
So I see Chandra Shekhar is
Oh,
joining.
Chandra's here. Oh, great. Chandra from India.
Yeah, I'm going to promote him.
You probably know him, Jack.
I do. Yes, I know him well.
Very good, man. Great. Hello, Chandra. He does a lot of webcasts. Matter of fact, let me give Chandra a plug. Let's see here.
There you are.
Very great. Nice to see you, Jack.
Very nice to see you, Chandra. How you doing?
I'm good, thanks.
Good.
Hi, Chandra. Nice to see you after Bogota.
Hi, Dr. Beltragi. Good to see you.
Hi, Chandra. You're right.
this message across. I said I must see all friends and listen to some of Jack's talk after a long time.
Okay, Chandra, here you are on next Sunday.
Okay.
And then there's grand rounds on Sunday at 5 o'clock India time.
Thanks,
Oh,
John.
nice.
Sure. How you been, Chandra? Okay, 1 minute,
Well,
Llewellyn.
it's nice to see Chandra because I'm not the only old timer here then.
Let me just see if we have any of our.
Okay, are we waiting for someone? Do you want to wait a few minutes?
No, I think we'll try and get started on time. If any of the CAANS guys join, I'll just sort of introduce them as they come along.
Okay. Here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach. This is Dr. John Bennett broadcasting from Egypt and Africa, a pediatric neurosurgery webcast with Jack Walker of Pearls of Pediatric Neurosurgery. And I'd like to welcome the moderator, Llewellyn Padayaki from South Africa. Welcome, Llewellyn. It's all yours.
Thanks so much, John. So firstly, on behalf of Mohammed Al-Beltagi and myself, who've been running this webinar series under the auspices of CAANS for a while now. I think we're on our almost a dozen now. Hey, Mohammed, we always sort of start off by thanking both Moody and Bello Share, who have supported this initiative. So Mohammed, I'm going to hand over you to say a few words, and after that, I'll introduce our speaker, Jack Walker.
Yeah, thanks, Llewellyn, and thanks, John, for the broadcasting. It was very helpful as usual. We're back again in the webinars after stopping for 2 months for the holidays and for traveling to the WFNS. So we always run the webinars on the second Tuesday. I just want to remind you, on the second Tuesday of each month on pediatric series. And today we are having Dr. Jack Welch, which will be introduced, Jack Walker, which will be introduced by my co-host, Dr. Llewellyn Badayashi. Yeah.
Okay, thanks, Mo. And like we said, we've run the series now over a good couple of months and had some really interesting talks, interesting speakers. But there are few occasions that could be such a tremendous pleasure, a privilege, and an honor for both myself and Mohammed to introduce somebody the magnitude of Jack Walker. And despite all his tremendous career milestones and achievements, which are really unparalleled in many ways, academic excellence, scientific distinction, surgical prowess, many of you may not know, but Jack was a past ISPN president. And just to show the kind of, the caliber of attendees, we have another previous ISPN president in Chandrasekhar Dayapujari, who's also attended. So welcome, Chandra. So Jack, I think despite all of these things, he's most revered by his trainees and those he's mentored, something that I am privileged to consider myself, part of him being a mentor to me particularly, and inspired me very much to a career in pediatric neurosurgery. So I'm sure that the talk that Jack will give, and he was previously the head of Primary Children's Medical Center at University of Utah, and I think was the primary captain to driving it to real sort of global stardom. So I think a lot of you would get the same inspiration that I have gotten from Jack, I hope. And Jack, with those few words of introduction, I'm going to hand over to you now to inspire a few more neurosurgeons.
Well, thank you, Llewellyn, very much for that kind introduction. It's my honor and privilege to be a part of this, excuse me, this webcast. I think it's exciting that you guys are doing this. I didn't know about it before Llewellyn approached me, but what an honor to be able to be a part of it. I thank you. He asked me to talk about some pearls that I've learned through my career, and that's kind of difficult to come up with because any pearls that I came up with, I think, are old hat by now. But nevertheless, I'm going to try to share some of the thoughts that I've had and some of the excitement I've had through my career. I want to do this by first, I want to share my screen, so give me a moment. Whoops. I got to get this back in order. Hold on. There we go. So I've really had the privilege to see amazing developments happen in neurosurgery. I started at a time when neurosurgery was still young in the sense of what we know now as the technologies that surround us. But I've had the privilege of seeing so many things develop, and I want to share some of that with you just to remind you of the journey that we've been on. I graduated medical school in 1969, and I did my residency at the Barrow Neurological before going to Toronto to do a fellowship in pediatric neurosurgery. But back at that time, we were doing air studies and angiograms. It was before CT scan. And in one sense, it was an honor to be able to experience neurosurgery before the change that CT brought, because it certainly gave me a perspective of the ability of diagnostic, the diagnostic abilities that have been developed. If you're young, which I think most of you are, you've probably never done a pneumoencephalogram or a ventriculogram per se, but that was a very common way of doing things. And we also used to stick carotid arteries just to get the angiograms. Angiograms were developed by Igaz Moniz in Portugal way back in 1927, but he went on later to gain the Nobel Prize for his work in developing cerebral angiography. And it was a significant improvement over the ability of just air studies. So it was one of the steps forward that I was able to see as a young resident. But CT scan changed the world. I think you probably know that, but if you see this image with, it's so pixelated, and nowadays we have such amazing images, but look at just this dark area right here. We thought that was the greatest thing in the world to be able to see something like that. It just was magic. And it obviously changed a lot. The CTs evolved to become, part of our everyday armamentarium. And then along comes MRI. A researcher in 1973 showed that nuclear magnetic resonance could produce images. And the British scientist Peter Mansfield developed the mathematical process to make this, to turn it into MRI imaging. And these two gentlemen were awarded the Nobel Prize in 2003. The MRI changed things from the CT. It changed better quality imaging in the sense of brain parenchyma. We had a much better idea of what we were dealing with. And you know this, and then along comes more modern techniques such as tractography. These changes were incremental, but truly had an impact. As a young growing neurosurgeon who I happened to be growing up at the same time that these that these changes were coming about. And it made such a difference, obviously. And the Minus Rex was another tool that made a big change. The ability to very precisely use a drill in neurosurgery changed a lot of the way we could do things. One other thing that I had the privilege of being involved with was being a part of the development of the BRW stereotactic frame. I was a young neurosurgeon on the faculty at the University of Utah. I didn't have any direct input into the design and the mathematical and imaging background of it, but I was part of the early trials in our patients to improve the early stereotactic frame. And looking back, again, it's something that changed the whole direction of my career to be involved with this process. And then since then, of course, navigation has become in powerful and indispensable and in neurosurgery. Medtronic, the images here, has led the way in developing a lot of the navigation systems that we use, although other companies now are also involved with navigation. Now, let me go back to Medtronic, and perhaps others that I'm not aware of, is developing using heads-up technology like fighter pilots use, and also like we're beginning to use in our driving automobiles. But this navigation is so important. And in a sense, it all comes from that beginning of the BRW navigation frame and the ability to very precisely pinpoint. If you think about it, it has let us go into places within the brain parenchyma that we could never go before, that we didn't dare go before. So, and if we think of imaging as pneumoencephalograms and CTs and MRI, and then we think of navigation and the stepwise progress that it has made. These tools have changed neurosurgery over a 40-year period that I wonder if any other surgical specialty has seen such dramatic improvement. So what have I learned through all this? Well, you've all heard the phrase that children are not small adults, but I certainly believe that. I certainly learned that because what we do, we treat different diseases, different than our adult colleagues. If you think just about brain tumors, what do we see? You know, we see posterior fossa tumors that are benign. We see craniopharyngiomas more often in children. We see that we're able to cure. You know, when I first started in practice, medulloblastoma had a survival rate of less than 40%. And now it's greater than 80%. It may be approaching 90. That ability to treat aggressive tumors in children has been dramatic. And it's related to the focus that has occurred over time for brain tumor study groups that have focused on cures. If you compare it to what's happened with glioblastoma, when I started practice, the survival rate for glioblastoma with surgery, radiation was 12 months. And now the survival rate for glioblastoma with surgery and radiation and chemotherapy is 15 months. Just think about the progress or lack of progress that's been made with that one tumor and compare it to what we've been able to accomplish in children. We treat different diseases, and it's been important that, at least from the pediatric community, we've focused on those diseases. We obviously treat more hydrocephalus than our adult colleagues do. We treat craniosynostosis, congenital birth defects, and on. So we treat different diseases, and it's pretty obvious. We watch our patients grow up. We create a bonding with our families that is often lacking from our adult colleagues. It's just the nature of taking care of children. You know, I've always thought that for a parent to hand you their infant, to let you do surgery on the brain, they must have an incredible amount of confidence to do that. And it's a blessing that we have that very few others do. Another thing that I remember from my days as a fellow in Toronto at the Hospital for Sick Children, Bruce Hendrick was the chair there at that time. One of his favorite sayings was, "Whatever mother says." Well, at the time I thought, well, that's a cute saying. But since then, I've grown to believe it myself, because you listen to mom. She knows that child better than anyone, including you. That doesn't mean mom's always right, but you listen, because whatever mother says is a very important guiding principle I think we need in pediatric neurosurgery. I'll stop here before going on to a different topic. If anyone has questions, I'd be happy to answer them now. We can wait till the end, whichever is best.
Thanks, Jack. Might be worth just seeing if there are one or two questions. I think you've covered quite a spectrum of things. John, do we know if there are any questions? No, perhaps I could ask either or one of the panelists. Mo, any questions or any comments from your side?
No, I think it's very clear now. I don't think.
Yeah, perhaps Chandrasekhar, any comments from your side?
I can only say I joined about a few years after, about a decade later, probably, but have because I come from a country where these kind of advances probably reached a little late. I ended up doing pneumoencephalography, ventriculograms during my residency. And in the last year of my residency, we got the CT scan. So I have some first-hand experience of how we managed before then. And it is like, you know, you have come from the old yellow lamps into suddenly in tube light fluorescent lamp, and now we have gone into LED lights. So it is that kind of a transformation that has occurred in terms of images. And I'm not sorry about the fact that clinical medicine, not only neurosurgery, but I think generally clinical medicine has probably become too much of investigations rather than, and that is a lament I have with this kind of a progress. I don't know how it works in United States, but it has already become a problem in India that, as Jack correctly said, we develop a bond and we are treating the child and the family. But sometimes you are probably treating what only your investigations tell you, what your MRI tells you. So that has been one sort of what should I say, pitfall of what progress has taken place. On another note, I just wanted Jack. I'm sure he probably didn't mean this, but though Egas Moniz got the Nobel Prize, he didn't get it for his angiography. Egas Moniz actually later on developed frontal lobectomy as one of his passions, and his Nobel Prize came from his psychosurgery. So
Well,
just
thank you. Thank you. I didn't realize that. I will certainly correct that slide. Thank you. And I think your comments about imaging, and it can take over your life as a neurosurgeon and you forget about the patient. It's all about the image. Unfortunately, I see this in some of our younger residents that you'll ask them about a case and the first thing they'll say is, well, what did the CT scan show? Well, no, that's not what I want to hear. I want them to ask me what the exam showed or the history, you know. So sometimes our focus can get carried away, and that's why I tried to show that that's important to remember the bonding and remember the family and remember that mother knows best. Yeah.
Thanks, Chandra. Perhaps I'll just add a quick comment there, Jack, before we let you go on. I mean, despite these advances, some things are modal, like, 60s trends that come back. So when I was at Red Cross Children's Hospital, the group there were driving quite hard, pneumoencephalography for diagnosing, communicating hydrocephalus in tuberculous meningitis. And that was a sort of, departure point for the treatment protocol. So, some of these things go in cycles. They have resurgences, they don't just disappear.
Very simple and very effective way of.
Thanks. Okay, Jack, we don't want to keep you too long. Just as I say, if you want to carry on, that'll be great.
Okay, let me try sharing my screen again. Now, one of the passions I've had in my career has been treating patients with spasticity. There's a special type of patient, a special type of family. And so I want to share some of my thoughts with you regarding selective dorsal rhizotomy. And Warwick Peacock came to Salt Lake City in 1984 to the pediatric section meeting of the AANS. I had never met Warwick prior to that, and he made his presentation on selective dorsal rhizotomy. I thought that was just amazing. He did such a good job of presenting it, but I was enthralled with what he was talking about. I made plans to go to Cape Town the following spring in 1985 to basically learn from Warwick. I spent 2 weeks there, visited patients, examined patients, worked in the OR with Warwick. And I came away from there totally convinced that this was a great procedure for children with spasticity. I came back to the United States and actually performed the first selective dorsal rhizotomy in North America. About a year later, Warwick actually moved here and came to UCLA. And it was really, really nice to have him close. I don't need to go over with you about it, but Warwick, his ability to show how you could separate out the rootlets and treat them, I think changed the world in a sense of the treatment of spasticity. Now, no longer was it just physical therapy, and you may or may not have made some progress, but in the properly selected patient, Warwick was able to demonstrate the benefits, and that's going on, of course, now to be documented and shown over time. The only thing I would add is that for a long time I did the large laminectomy, and after a period of time, my colleague in St. Louis, T.S. Park, had been doing the small incision at the level of the conus. And at first I was critical of that, but he continued to show good results. So I went to spend a week with T.S. Park in St. Louis. And I must say, I came away from there believing that this was a step forward. And I have, since that time, I performed the single level laminectomy. So it's something that if you've been doing the large open procedure for a long time and you don't want to change, then I'm not suggesting that you have to. But I was personally interested in the smaller incision and the much less discomfort that it caused the patient. So if you want to try it, you need to scrub with somebody who has experience with it for a few times, and it's not very hard to learn. But it's again a little minor step forward in the way we treat patient. Any questions about rhizotomy and the experience with it?
Maybe just a quick comment or question to Chandra. I know there was a guy from Hyderabad who was talking about the super selective dorsal rhizotomy a while ago. I'm sure there are others doing it. Any experience with that, Chandra, from your side or any others?
Actually, Lillian, one of my regrets is that we could never actually get around to popularizing or doing rhizotomies on a regular basis. So no personal experience at all. But this colleague of ours from Hyderabad, he's actually gone to peripheral neurectomies close to the muscles rather than going from groups to groups, rather than working on very selective rhizotomies. He's also changed his procedure. There is some work published, but I think a lot of his data is unpublished. I think in India somehow dorsal rhizotomy did not catch up, and baclofen pumps came too quickly. So I think that is where we stand.
There's a very interesting article that one of our residents took the time to put together. It's by Peter Kahn, K-A-N. It's probably 10 years ago or so, but he compared he graded patients exactly the same for baclofen pump and the rhizotomy that we had done in our practice, and compared them outcomes and so forth. And I was quite surprised at how much better the outcome was with the rhizotomy. Again, some patients benefit more from the pump, some the other way, but there was quite a benefit from the quadriparetic patients with rhizotomy. But the baclofen pump, I've done a lot of them, but it's another shunt, and it's not always something that works well through time.
It's the fear of any invasive procedure rather than any other reason, to tell you frankly.
Yeah, well, you're cutting a nerve, so people worry about it.
Yeah.
But okay, well, let me go on to my next topic here. I will. Now, another topic that sort of came along during my career that I think was interesting is because of imaging, And because of some pretty brave and aggressive neurosurgeons, we began to see more and more opportunity to operate in the brainstem and in the spinal cord. And over time, it became obvious that some of the pearls about operating on these tumors were that you had to obviously stay within tumor. And in reality, the only tumors that are going to be successful are those that have a nice tumor interface with normal neural tissue. So staying within the tumor, using your imaging, importance of monitoring. And the one pearl, if I had to give you one regarding brainstem tumors, is stay away from the obex. Never go through the obex. Now that lesson's been learned. One of my colleagues who did a lot of brainstem medullary tumors would typically split through the obex. And almost without exception, his patients would have a peg and a trach, percutaneous gastrostomy and a trach, almost always. And knock on wood, I never had a patient that had to have a trach and a peg. And I'm convinced that the difference is the obex. And if you are too aggressive and they're going through the obex, you're going to get in trouble. Obviously, you want to stay in the midline as much as possible for these lesions. And again, I can't tell you more. Just to stay away from the obex. It's so important. But with imaging, it gives you much more confidence of where to approach it. You want to get into the cystic part first before you split into the cord or the lower medulla. Once you open, you can see a very big bulging area. And it's not unusual to have basically a lesion or a postoperative image that looks like this with a big cavity, but a nice interface between normal tissue and tumor tissue. And I think that the lesson, the pearl, or whatever you want to call it, is staying within tumor, staying within midline, and do not go through the obex. Even if you have to go low and go up, you still don't split through the obex. And that's, I guess, probably the only pearl I can share with you on that. If anyone has any questions about that.
Yeah, Mohammed, you do a fair amount of these posterior fossil tumors, probably more than most. Any comments there, Mo?
Yes, actually for the intramedullary tumors, I just finished one of them 1 hour ago. So how trustable is the intraoperative monitoring you're using, Jack? Like, how do you trust that it's like with a 20% error, or when you talk to the patient that you're using IOM during the surgery, and you will be avoiding any weakness or bulbar symptoms, but there are still machine error and doctor errors that could happen. So is it 10%, 20%, or depending on the neurophysiologist you're working with?
I'm sorry. So you're asking basically what I'm going to tell the family before surgery? Well, they are aware, obviously, of this, of the significance and seriousness of the issue. I tell them that I expect there to be a quadriparesis, maybe a quadriplegia for a short time afterwards, and that I expect it to improve, that the patient will almost always be left with some quadriparesis. Hopefully something that's improving over time. I have one patient who made a dramatic recovery in terms of strength, but then 5 or 6 years later developed a pretty significant amount of spasticity and ended up with a baclofen pump. She still walks and gets around, but that's the only patient I've seen that ended up with no spasticity for 5 or 6 years and then ended up with enough that needed treatment. I don't usually tell them a percentage, but I tell them that I expect there to be some quadriparesis and also associated bowel and bladder dysfunction for a while.
So the intraoperative monitoring using it would reduce this incidence. Like if you have changes of the waves during the surgery and you stopped and then you continued, but at the end of the monitoring, you got a wave change, a depression. Do you find this recoverable after that? That's how often do you find? Yeah, how often when you get lower waves after the surgery by the monitoring, and then afterward it sounds to be that it's a false one. The patient is okay, or the reverse.
If it happens while I'm operating, I back away, take my time, and if it keeps happening, I stop in that particular area. But if it's happening right at the end and things have gone okay, I'm not as worried about it. I've finished. I'm not operating anymore, but they're telling me there's some changes. I worry about it, so to speak, but I don't, as not as concerned as I am during the procedure.
Mm-hmm. Yeah.
Monitoring has improved so much compared to when I was doing it that it's I'm sure more and more believable as we go along.
Yeah, sure. Actually, I don't use the monitoring. Yeah, I just did one, but it was a phylum terminal ependymoma in a 13 years old boy. I was using the monitoring and they have to stop because of bladder changes, but then irrigation and waiting, it recovered. Then I continue until it ends up normal at the end. But sometimes the neurophysiologist stopped me forcibly by that the changes are permanent and you have to stop. And after that, the patient recovers completely normal. So I regret not removing the last part. That sometimes happens.
That's the value of experience as a surgeon. You sometimes can develop that feeling where I should have gone on, even though the neurophysiologist is telling me something, but that he or she doesn't have that same experience that the surgeon does.
Yeah.
The bottom line is it's hard to know exactly what to do. Obviously, we try to use all the tools that are available to us, but experience makes a big difference, I think.
Sure. Yeah, sure.
And that comes with time.
Of course, yes.
Jack, maybe just while we're on now, while your talk, I don't know if you're going to come to it a little later, but while we're on, brain stem tumors, I think the nemesis for almost all pediatric neurosurgeons is the DIPG. You almost always stand by helplessly and watch patients inexorably deteriorate. And in your career, you say you've seen the improvement in outcomes from medulloblastoma. I mean, is that something you think is likely to change ever, or do you think it's always going to be just a very sort of nihilistic approach that we take to that?
I'm sorry.
For the diffuse intrinsic pontine glioma.
Okay. Yeah. Well, I think they are in a sense equivalent to the glioblastoma that we talked about for adults. It's a tumor we haven't made progress with. it doesn't seem reasonable to think that we won't make progress. I think we will, but it's going to come down to molecular, genetic, um, um, it just doesn't seem to be one that a surgical debulking is going to be the answer
Absolutely.
for. Surgery will maybe be related to a biopsy and a tissue, an importance of tissue sample, perhaps, and maybe even at some point infusion into the lesion, but it's just not a localized tumor. It's everywhere, as you know.
Okay, thanks, Jack.
This was just one comment I would like to make, Llewellyn.
Yep.
Uh,
Yep. Please go ahead, Chandra.
Right. I think what Jack mentioned is what we have sort of come up with, the midline incision being our mainstay for, debulking and probably removing these tumors. I think the IONM has made one change apart from probably the lessons we learned from Vermeer split. Somehow the approach to at least higher tumors, not strictly within medulla or in that sense intramedullary, but tumors which are higher than the lower cranial nerves. The tendency seems to be more to go as laterally as possible rather than going to through the midline. Any comments on that by Jack or anyone?
Well, I think tumors of the peduncle
Yes, correct.
are ones that you approach those laterally almost always. So I was referring specifically to the cervical medullary lesions, but
Okay.
So certainly the higher up lesions, the peduncle lesions, I think you have to come at laterally, and the tectal lesions, obviously you come at from a different direction from either the posterior fossa or above the tent. Yeah.
Yeah. Thanks, Jack, for the clarity.
Yeah.
Thanks, Jack. If you want to continue.
Well, the other thing I got involved with was Craniopegas Twins. And again, you guys know a lot of this, so I'm just going to share with you that how I got involved with it. I was a very young neurosurgeon when I received a call from an obstetrician announcing the birth of Craniopegas Twins. I arranged for their transfer to the NICU at the university, and I had not previously treated any twins like this, and I was at a loss as a young neurosurgeon. Started to think about what should I do, and at that time there was only one previously long-term survivor reported, and there had been no cases where there were two survivors. And I talked to my chairman, who was Dr. Ted Roberts at the university at that time. Ted Roberts began reviewing some of what Oscar Sugar had written about his experience in Chicago and developed a plan. And there are 5 fundamental problems when you think about the eventual separation. And one of them is closure of the skin, obviously. And so we got plastic surgery involved to place expanders. Another problem is brain parenchyma. Is it fused or is it just interdigitating? There's all kinds of conjoined twins. Llewellyn can tell you that from his recent experience with one that was connected with the spine. But the brain parenchyma, in my experience, has been very commonly involved. And then the issue of arterial bleeding and bridging. And surprisingly, this has not been as big an issue as you might think. The blood vessels go back and forth, and the severing of these vessels, at least in my experience, has not been a problem. The big problem is the venous drainage. And most of the patients that we are able to consider separation, the problem is a shared superior sagittal sinus. And the issue is correcting the venous drainage so that both twins can survive. The fifth problem is, if you're operating, is to try to prevent adhesion between surgeries, and the placement of a silastic sheet between the hemispheres where you have operated is an important thing to consider. So, as I've mentioned, they share a common superior sagittal sinus, but it's almost always a circumferential sagittal sinus. It's not down the midline as we tend to think of it, as you see here in this illustration. So the options for separation, of course, are you can do it staged or non-staged. And the approach that we took was to stage it so that we had a chance to reroute the venous drainage. Now, I'm showing you images here from our last case that I was involved in, which was in 1996. But the first set of twins in 1978, we went very slow. We would operate, we would take one of the bridging veins or two, and we'd stop and we'd wait a few weeks. We'd come back and we'd take another one or two of the bridging veins, and we'd stop. We took almost 3 years before that separation occurred. The second set that I was involved with at the University of Utah, we took almost 2 years to make the separation. But this set, as you can see, they showed for us in March, and we made the separation finally by September. And I think that was basically part of the learning curve, that we had a better sense of how fast we could go in terms of clipping of a bridging vein and waiting and come back and clipping some more. But in the stage separation, you eventually get to the point where the final separation, at that point, you know that you've clipped all the bridging veins, and one twin has deep drainage. The second twin has the sagittal sinus, so that when you finally make that last separation, you know that both twins have that deep drainage. It doesn't change the fact that they may have deficits from other issues, from shared brain and other things that may have occurred, but it does let you know that their deep drainage is in fact intact. And if you'll compare the February sagittal sinus drainage and after the clipping before the final separation, you can see that we have shown an increase in the deep drainage system. Not all twins are appropriate, obviously. The ones on the left, you can tell right away. The ones on the right share a common torcula, and they're just not the kind of separation that you would want to do. But stage separation has now become the standard that people consider to follow at the time of separation of conjoined twins. And again, when we did our first set, excuse me, it was the first time there were 2 survivors. I was involved in 3 sets at the University of Utah, and we had 6 survivors. All 6 of them, by the way, have graduated from high school. Jim Goodrich had a set of Siamese twins or conjoined twins, Craniopegas twins. And he came to Utah to talk to us about our approach, how we did it, looked at our data, and went back to New York to apply that stage approach to his twins. And of course, Jim went on to be the master of it. He was involved in I don't know if I have the numbers right, but I think it was 7 separations, and then multiple times he was consulted for others. And he went on to really perfect it in a sense. So that's, I think time-wise, I'll stop here. But I'm happy to answer questions, and again, I thank you for this privilege.
Thanks, Jack. I'm going to just open up for some questions. Maybe, Mohammed, we can start with you, some questions or comments.
Yeah, thanks, Jack. First, after all this experience, what do you think about the medulloblastomas management? Since now, after this molecular classification, they are talking about that we were over-treating some of these medulloblastomas by totally excising them and leaving less than 1.5 centimeters. Although there are some after the classification that could be just biopsied and sent to radiation.
I think they're absolutely correct. I think it's more than one disease, so to speak. And I think we have to approach it genetically, not just as a mass.
Sorry about that.
Okay. I think it's a big change in the management of that particular tumor over the last 10 years, but it's more than one tumor. I think we see.
But Mohammed, unless we get that kind of a molecular information either on our frozen section or from the radiogenomics, that we can diagnose that kind of a tumor beforehand, it would really not be possible to, use this kind of information during surgery.
Yes, I totally agree with you, Chandra. That was my also thoughts. But there were some who said that it might end in ETV and endoscopic biopsy, and you don't have to do a big surgery and then send them to radiation because the results would be the same. Some of the sonic hedgehog and those who behave better would get, we don't need to do a big surgery. Due to the mutism and cerebellar mutism, which was the second question I wanted to ask Jack after all this experience, how to avoid cerebellar mutism during your surgery. In my thought, it was the retraction and the dentate nucleus edema and the invasion with the medulloblastoma itself. So if you have any comment about this.
I wish I knew the answer. It seems to happen when you think you've just done the perfect operation. I always felt it was related to either too much traction, distraction, and especially at the upper end of the lesion, at the near the opening of the aqueduct. I don't know that for a fact, but it always seemed to me that the superior part of it was the part I was most worried about, and certainly traction. Your comment, Chandra, about not being able to judge just from the biopsy and surgery, I think is going to lead to an approach that we're just not so aggressive surgically
Yes.
to do that. And a second look is, in some of these cases, a second look is going to be important. And in others, obviously, it's not important at all.
Yeah.
And if we approach it in that way of trying not to be as aggressive as we have been, we might see less of the mutism.
Yeah.
Absolutely. Absolutely.
I hope.
But I must congratulate you, Jack, on your work on Craniopegas, which paved the way for then Jim to take over, and we really miss him very badly. But
Yes, we do.
this disease has really been very nicely studied and has some sort of reassurance that one can do it. I mean, in the Delhi case, which was one of the first complex Craniopegas in Delhi, Jim was here for quite some time, and he helped quite a bit in getting that thing sorted. They did have some venous infarction, but both the boys eventually survived.
Yeah, see.
One in a very good condition, one in a moderate condition. So
Well,
really thanks for that kind of work and initiative.
thank you.
Yeah, Llewellyn, do you have comments, questions?
Yeah. So Jack, maybe some thoughts. So Christian Aquilano of Great Ormond Street gave a really splendid talk at the AANS, and he quoted a lot of the relevant work from Schmarman and Harold Recate. And when you look at the Delphi scoring and how he interpreted it, it suggested, and the conclusion of the talk was that the location of the tumor is more predictive of mutism than the actual surgical routes. In his analysis, transfermion versus telovelar tonsillar didn't actually appear to make any difference. So this idea of retraction then almost falls away. It almost appears as though no matter what you do, mutism is predetermined, which is a little disheartening to us because we spend a lot of time on surgical technique and approaches. Any thoughts on that, Jack?
I think that's interesting thought and interesting talk, and it doesn't make a bit of difference because nobody knows what causes it. It just happens.
Yeah, no, I think that's right. And the one point you make is, it's those operations that you're the most proud of. You've taken the time, gone through that telovelar tonsillar corridor and resected and monitored, and at the end, it's so disheartening. And just one more thing. I mean, the role that hydrocephalus perhaps plays in this pathophysiology, do you think the degree of hydrocephalus or the presence or absence of it is a predictor, rather more than the actual tumor morphology?
No, I don't.
Yeah. Okay.
I don't know why, but I don't.
Okay. Right. Yeah, look, Jack, I know you said you needed to head off by noon your time. So I think if there are any other questions quickly from the audience, John, if you have any, please just.
Yeah. I'd like to tell Jack. I'd like to get your email, Jack. Put you on the email list, and you can come in like Chandra did and add to the discussion on any webinar that we put on. So.
Thank you. I would like that.
Yeah, we'd love to have you just making comments and watching and helping the residents out like you did today. So I'd like to thank everyone. Thanks Llewellyn for arranging it, and Mohammed. And I guess we'll see you in a couple of weeks, right, Llewellyn?
No, for sure. We'll try to stick to our usual second Tuesday of the month, 7 o'clock, Central African time, John, and we'll keep you updated on speakers and programs.
Okay.
And thank you again. Thanks very much.
Okay. Thanks, Chandra, for coming.
Thanks.
Jack,
Thanks,
thank
Jack.
Enjoyed it.
Thank you.
All right. Cheers.
Bye-bye.
Good day. You keep on learning all the time. I'm sorry, I don't know where my screen has gone, but you can hear me, I suppose.
Yeah, that's good. It's good.
So basically, I think a lot of things have changed, and I'm sure the young people, many things will change in future. You may probably be not, debating these things, something else, but keep up with this and don't forget the patient while you are advancing in your field. That is all I have to say, really.
Okay. No, thanks, Chandra. All right,
Okay.
John. So we'll then aim to wrap up, I think, yeah?
Yeah, okay. Does anybody want to meet Llewellyn or meet anybody else in the panel? Any residents or any comments? We're off the air. It's not being recorded. So you don't have to worry about that.
Yeah.
Does anybody? Takashi, welcome from Japan.
Thank you, Dr. John. Thank you for a very informative webinar. I'm Dr. Takashi Kon from Tokyo, Japan. I'm studying neurosurgery, and I'm specializing in malignant brain tumor. But I learned everything. Neurosurgeons all over the country. Until my future. I learn from everywhere in the world, and I would like to communicate all over the world and neurosurgeons all over the world. Thank you.
Yeah, Takashi's going to be part of his team in the future. He's like me. He likes to travel and he likes neurosurgery.
Yeah.
It's a good combination using this tech to fulfill two of our passions. Llewellyn, can you do me a favor?
Sure.
Could you email me, send me Jack's email address, okay? So I can put him on the email list to let him know. I mean, it was great having Chandra come by and make comments. I mean, that's fantastic.
Yeah. No, fantastic. I'll send you those details this evening, John.
So
Okay, John, thanks a lot.
okay.
Thank
Was
All right,
great as usual.
great webcast, guys. Thanks a lot.
Thanks,
Thank
John.
you.
Thanks,
Bye-bye.
thanks.